Welcome to Quality Time, a Houston Methodist leading medicine podcast. I'm your host, Dr. Schaal, a clinician scientist and a retina specialist, and I serve as the Chief Physician Executive of Houston Methodist, located in the world-renowned Texas Medical Center. I passionately believe that quality is the heart of healthcare, and a commitment to quality is essential for every healthcare system. Join us each month as we discuss the latest advancement in quality in healthcare with clinicians, researchers, physicians, industry experts, and thought leaders who are as passionate as I am. I'm absolutely delighted to welcome today Dr. Terence Flotte. Dr. Flotte is the provost and dean of the UMass Chan School of Medicine. He is the Celia and Isaac Haidak professor at UMass Chan Medical School with faculty appointments in the Department of Genetic and Cellular Medicine and Pediatrics. As provost and dean since 2007, Dr. Flotte has led the creation of 10 new academic departments and has overseen tremendous growth. This conversation is particularly special to me because Dr. Flotte was my boss, my dean, when I was the chair of the Department of Ophthalmology and Visual Sciences at UMass Chan Medical School. Welcome, Dr. Flotte.
Well, thank you. It's great to be here and have this conversation.
So first, please introduce yourself. How did you get to be dean and provost? A little bit about your background.
Yeah, no, it's great to have a chance to talk with you. So did the bulk of my pediatrics training at Johns Hopkins, where I was a pediatric resident and pediatric pulmonary fellow, and got really inspired there about physician scientists and academic medicine in a place like Hopkins. And so I was given an opportunity to do extended research training. That opened the door for me for many different things, because it was right at the dawn of the gene therapy era, late 80s and early 90s. When I went back to Hopkins, well, I was always a Hopkins person, but when I had a lab experience at NIH, and when I set up my own lab back at Hopkins, I was able pretty quickly to get NIH funding in 1993, and ever since then, well over 30 years now, continuous, and worked on gene therapy for cystic fibrosis to start, and then many other conditions, single gene disorders. And that caught the attention of some people. So I was recruited to the University of Florida to be the co-director of the Genetics Institute there, which became Gene Therapy Center, which became the Powell Gene Therapy Center, and then the Genetics Institute. Ultimately became chair of pediatrics there, which was a wonderful experience, pediatrician in chief of the Children's Hospital. And ultimately from there was recruited here to UMass Chan to be dean and provost. And I'll say it was an evolution over time, but I think the thing that inspired me to want to be chair and to then want to be dean was my appreciation and drive for all of the missions of academic medicine and for how they come together in our academic clinical departments, the research, patient care, the education. And we strove to make all of those better as a chair. And that kind of was why I think that I ended up being chosen for this job as the dean. And likewise, I think, these are we often think about these in academic medicine, and sometimes I've heard people say, well, how can you prioritize all those different things? And I always say they're actually mutually beneficial. They're really very important. And I would often talk to chairs about kind of the three missions as kind of parts of a pyramid. The base of it all for a clinical department is to have outstanding patient care, then build the education on top of that. And then the crowning part is to generate new knowledge through research. So I think that's kind of what got me into it. Really learned a lot all the way along and continue to evolve in the role, I would say.
So it's it's very impressive that you rose up in what we call a traditional pathway from a clinician scientist to a department chair to a dean, we now talk about healthcare and healthcare in this country, and the majority of healthcare systems are really not led by physicians, and only 15% of healthcare CEOs hold an MD or PhD degree. And so why is it important, or is it important to raise the next generation of physician leaders, starting from medical school and rising through the rank of academic medicine? Why do you think it's important?
Well, healthcare in the United States, I think, is operates both as a big business and also as a mission-driven organization that is serving the community and training the next generation. Because we all depend, as deans, we all depend on our clinical partners. In some cases, that we have kind of a blended relationship with. In some cases, they're separate, but we all depend on that. And likewise, I think that the health systems depend on the medical schools to continue to train the ongoing physicians that are needed for the ongoing need for the physician workforce. So I think medical schools and health systems need each other, and there has to be some alignment of mission priorities in that. Not exactly totally everything 100% aligned, but there needs to be some common shared principles, goals, values, and that I think makes it work better. I also think it makes it a better working environment for physicians within those organizations.
So UMass Chan Medical School that you lead has several clinical partners. One is UMass Memorial Health, one is Leahy, and then the third one is Bay State. How are they different, and how are the path for your students different?
Yeah, so that's a great question. So UMass Memorial Healthcare was integral to UMass when it was UMass Medical School. It was then separated from the school formally and merged to the Memorial System to create UMass Memorial in 1998. And that relationship remains unique because we have about 1,000 physicians now that are dual employed between the UMass Memorial Medical Group and the UMass Chan Medical School. So that's a unique relationship. And then we have, we share our principal university campus, and there are a lot of aspects of that relationship that will not be repeated in the other relationships that we had. However, on the mission of training medical students, we need more. Believe it or not, we continue to have a physician shortage. We have not caught up with that. We have a physician distribution problem. We also have a problem of certain specialties being undersubscribed, or certain, including primary care, but also including various pediatric subspecialties, surgical subspecialties. So we've had to train more than what we were able to train at UMass Memorial through the clinical through their clinical period. And really the rate limiting step has been the clinical experience locations. So that was where we, originally back in 2015, we signed an agreement with Bay State Medical Center and Health System, learned a lot from that relationship. We decided that we should give it a unique identity. It came on as a regional campus. It's a clinical campus, so it's the final 2 years of medical school are there. But students choose to apply to that pathway early on, actually as before they're admitted. They are motivated because that program has an emphasis on population health. So that fit really well with what Bay State wanted to accomplish, and that's been a very successful relationship, and it's actually grown. Then much more recently in 2021, 22, we got into discussions with BI Leahy Health, and particularly the Leahy, traditionally called the Leahy Clinic, like Leahy Medical Center. To some extent in the org chart, we modeled it after the Bay State relationship, but it was at a different emphasis. Leahy Clinic has a long history of being founded as a physician-run clinic, which then built the hospital, et cetera. And that physician-led model led them to think that the best way to carve out that relationship was for leadership. So we call that the Lead at Leahy track. These tracks have been very popular in addition to just enabling us to expand our total amount of graduates, which they've helped us to expand dramatically. We've doubled our class size. Students who want to train here to kind of differentiate themselves, to have a bit of a different experience all the way along. I mean, it's equivalent. They have to end up reaching the same standards, but it's the emphasis of it is different, and the attributes of the students who choose that are somewhat different.
So do you see them going to different residencies? For example, in Bay State, where the focus is population health, do you see them more going to primary care? And where in Leahy, would they go to different specialties? What are you seeing?
Well, it's very interesting because we do see a good representation in primary care, actually both at Worcester and at Springfield in their ultimate residency choices and matches. But students also are matching into selective subspecialties in some cases, because as they go through their clinical rotations, they discover that they might love a different specialty. Of course, in the end, what we're about is helping the students to achieve their full potential. And so we don't steer them too hard, but we do have a very good representation of primary care at Bay State. Leahy, we haven't, we're just in the second semester of the first class, so we don't have any results yet on that. So we'll tune in. Have me back in a few years, and I'll tell you.
Fantastic. I want to just ask if the curriculum in Leahy, is it different? Are there modules or subjects that are presented to the students that are different than the other locations?
It's a great question. The answer is yes. In both cases, there is an augmentation to the curriculum that we implement through our we call our Doctoring and Clinical Skills course, and it's really the extra activities that they do, many of which are out in the community, or they also include, in the case of the leadership, invited speakers. These are both driven by the faculty at those campuses, but they're also aligned to the themes that we mentioned before. And I should have mentioned part of the pivotal aspect of these being regional campuses is that we actually have regional executive deans at each campus, and we have department chairs who are full department chairs at those campuses. And so we not only we're not trying to just use them for some purpose of clinical material. We're actually partnering with those physicians of theirs that are very interested and want to get involved more deeply with academic medicine.
So I know you serve on the board of the Council of Deans. What is the Council of Deans, and what's your role there?
Yeah, so all of the North American accredited medical schools join the AAMC, and when they do that, the person who is the overall dean of that school is sort of automatically becomes a member of the Council of Deans. So we are composed of the members of the deans of all of the member organizations, all the member schools, which is only still a little over 150. In the country. So it's actually a very manageable size group. And, on the board, we've been, in the last few years, we've been working hard to make the participation in the Council of Deans more meaningful and helpful to the members. So we've been not only planning, the annual meeting, our component of the annual meeting, but we've been working in collaboration with some of the other groups within AAMC, and we've also been coming up with additional programming and analysis of deans and what do deans need to continue to be equipped and to kind of retool themselves, and also, how can we help deans be more fulfilled in their jobs and have less turnover.
In as you discuss in these meetings, you talked about the annual meeting, but you meet more often than that. I think you also have monthly meetings with other deans. Do you discuss how should we train the medical students differently now that we are, in evolution? AI is coming. To prepare the medical students to be the physicians of the future, how can we prepare them better or differently?
Yeah, it is a topic that we discuss, and certainly at our we have a spring meeting that is just the deans. We have a fall meeting, or it's this year we're doing it in combination with the health system executives, but then we have programming at the fall meeting. And a lot of those things have been dedicated to changes in medical education.
So what are the changes that you've seen since 2007, like major changes in education? Just give us an example. What is a major change? Because I remember, when I was in medical school, and so I have a vision in my mind of how students learn medicine. Obviously, I hope it's awfully outdated. What have you seen since you became dean in 2007? What are the major changes that happened, under your watch?
Yeah. So the first thing was when I took over in 2007, we had a preclinical curriculum that was the very classic curriculum. So we had a course in anatomy, a course in biochemistry, a course in pathology, a course in physiology. And the first thing we did in the first new curriculum we brought in is to basically merge those disciplines and do an organ system-based approach to the preclinical education. And then that's evolved again. We're on our second new curriculum now, about one every 10 years, and it has further condensed that and included more case-based learning in the preclinical years, more team-based learning, and evolution away from lectures. I will say that, in the life of a medical student, a huge change was when the USMLE Step 1 exam went to pass-fail. And you might say, well, that's just an outcome measure for what you're doing. Well, it's an outcome measure that's had far-reaching consequences because, as you would know, as a department chair, we've a reformed department chair like myself, you would know that we used to really rely on that Step 1 score in addition to the clinical clerkship grades. We used to really rely on that to give us some differentiation between students that are, likely to do well and pass their boards when they finish their residency and so forth. And that went away for good reasons. It became pass-fail for good reasons. But it's actually made it even more challenging for students to differentiate themselves. And so, that the trend that had been to being all consumed and getting a high Step 1 score, that was distorting the curriculum to some extent. And now the trend is, to pass it, but to publish as many papers as possible, especially in the selective specialties like ophthalmology, and so that's been a huge change in their lives.
So you talked about doubling the class size. However, the residency spots have not doubled, right? And so, there is a physician shortage, and we know there is a physicians shortage all around the country, but also mainly, in specific states or areas. How are we addressing that as as healthcare leaders?
Yeah, actually, as it turns out, the federally funded spots have not increased, but hospitals and health systems have funded more and more through their own revenues. And we still are not seeing a significant proportion of U.S. medical school graduates to not match when they graduate. The numbers are pretty steady for the last several decades. So I don't really think we've saturated it, but it's not because the usual source of money, the Medicare Part A, it's not because the number of slots have proportionally increased there. It's because hospitals and health systems, realizing this problem, have decided to invest more of their own
Yes,
funds
and
into.
that's as healthcare systems also get budget constraints, that's also in danger. I'm seeing shortage, for example, in pathologists. Maybe when you're talking about the curriculum, maybe the fact that we don't have a 2-year pathology course now, like I did when I was a medical student, maybe that less of exposure gives people kind of cold feet to go into a field like pathology. So there are several areas within medicine that less people go to. Have you seen that? Are you trying to mitigate that through the curriculum and teaching?
Well, it's the whole thing about which specialties are popular and not. It varies quite a lot for reasons we don't always understand. I can think back to maybe 5, 6 years ago. Emergency medicine was very hard to get into. It became very selective. And then more slots were opened up, more residency slots were opened up. And then, perhaps some people had concerns as seeing what emergency medicine physicians dealt with in COVID. And now it's gone the opposite. It's just gone down. We've seen similar trends in fields like anesthesia that used to be felt as being very desirable because, of the managing the hours. The hours are more manageable for lifestyle, but now there's been a real decline there in terms of people choosing that residency. So the factors are really complex. I have not noticed the pathology one, but I'm going to talk to our chair of pathology and see if
Yes.
I've
Well, my
been
chair of
paying.
pathology, he keeps telling me that's a real problem, and actually kind of puts the blame, if you will, on medical schools that don't expose enough as they used to basic sciences and to pathology in general. And the ones that get into pathology, they're extremely brilliant people. A lot of them have MD and PhDs. They do research, but just not enough of them, and so it became very competitive. But it's interesting. You talk to your chair and see what they're thinking. I wanted to ask you also about your role as the Dean's Liaison to AAMC group on women in medicine. I know you have been, a great supporter of many women, sent many women for professional development. I myself benefited from your sponsorship. Thank you. Tell me what you do there and why.
Well, I'll just say, I did that for 5 years, and then when I got on the board for the Council of Deans, I passed that on to someone else, the being the dean's liaison. However, I would say it was first and foremost a tremendous learning experience for me, to more deeply get into the data and evidence about what specific challenges that women in medicine and science are facing at various levels, going all the way from the student level, including, by the way, graduate students, all the way through to the more senior levels of faculty and leadership. And as the liaison, I would, among other things, try to carry information back from the GWEMS group to the Council of Deans. I would also give my feedback from a dean's perspective. We also did a number, as a group that while I was on at the GWEM steering committee, did a number of scholarly projects and published a few different papers looking at particular issues that might relate to the career trajectories that lead to deanships and how there are sometimes differential opportunities or differential uptake of the opportunities of being in certain roles that lead toward dean's roles. So, we tried to be responsive. And I just also say I was not at all leading that group because I was the liaison, but I did end up actively participating and really enjoyed that. I was also, the only man on the group.
We need men, right? I mean, to promote women, we need men. We need allies.
Yeah, absolutely. I mean, actually, it didn't bother me, but I think it was also helpful to be able to, I think both ways to be able to kind of give my own perspective as a dean and as a white male dean to which usually was not differing, but kind of trying to strive to understand where gaps between how people, what the effect people think they have on their faculty or others, and what they actually have.
Yes, the data is that there are more women deans than before, but not more than 25%. So 75% of them deans in this country throughout the years is dominantly male. However, it's interesting that in medical school, and you can tell me about UMass Chan Medical School, but in medical schools, usually it's now half and half, or maybe even more female than male. What's the situation at UMass Chan?
Well, we're a little bit of an outlier, I think, because we've had the last 3 or 4 classes, we've had between 65 and 70% female.
Wow.
And that was not because of them being female. This is something that's happened, and to be honest, we don't really even know all of why that's changed, or why it's why the male population now are underrepresented, so to speak. And
this is representative. I mean, this is in your school. Is it happening in other parts of the country as well?
No, we're more, well, I'd say across medical schools in the country, it's now slightly majority female. But it's been around 50% for the last few years. And, last year I think it was slightly majority female, but it's pretty close to 50-50. So I really don't exactly know what's different about us. We have great medical students, and we have, they are excelling in every way. We've actually grappled with this a little bit. I've asked the admissions people about this. And it's not obvious, actually.
And they're going to all specialties, or, I mean, they're obviously still today surgical specialties that have less women represented in them, like neurosurgery or orthopedic surgery. Do you see your graduates going everywhere?
Yeah, actually, we've had, I don't know why this is either. We've had an increase in the number of students going into orthopedics. Maybe it's because, it's something, even though he's not an orthopedist, our chancellor's taken a particular interest in. So that they've done very well. I will say, of our students who go into neurosurgery, we definitely have females most every year, but we it's more male than female for both neurosurgery and for orthopedics. Neurosurgery, I think we've greatly benefited from the current chair, Mark Johnson, and from the fact that we now have a residency. We had been, even as a major academic medical center, had been lacking a few of the residencies. As you know, you founded the ophthalmology residency at UMass Chan, and you've also since then we've had the ENT residency started, And right around the same time as you, we had the neurosurgery residency started. And actually, earlier in my time as dean, about 4 or 5 years in, we started the urology residency. So those four, which I consider major specialties, had not been represented. And so I think that's kind of helped. Each of those have gone up in terms of the proportion of our class choosing to go into those. And we've every year we have women medical students going into each of those specialties, actually. So
Yeah, fantastic. I wanted to ask you about health system science. We talk. This is a quality podcast, and we also talk a little bit about people coming from medical school. They have the medical school education. They start their residency, and then we ask them to meet all these kinds of quality parameters. What is health system science? Why is it taught now in medical school? And what are the areas of focus there?
Yeah. So this is a great question. So this is something I perceived quite a few years ago, that we have high expectations, actually, even at the GME level, of the ability of our residents to participate in quality and patient safety activities and be able to use appropriate methods of quality improvement. And we give them we prior to this had given them no real grounding in that. So they kind of started from that level. And I thought that's a real gap. So I asked some of the people who were most engaged in that activity, who were our faculty, if we could start a curriculum, which I was just going to call in my kind of rudimentary way, quality and patient safety. And they said, it's really part of a bigger picture of health system science, how healthcare is delivered, what the systems are like, what the payer systems are like, and what those incentivize are.
So this is now taught in your school?
Correct. We have some of it. It's a curricular thread. We have some of it in all 4 years. And in the first 2 years, we have dedicated modules within the doctoring course, and also in the course that we used to. It has a different name, but now population health. But we used to call epidemiology. We've added health system science. The kind of
so you teach quality improvement. You teach quality of metrics. You teach what is quality in healthcare. Those kinds of things.
Yeah. At the beginning level of the methods and the theory of that, and then going forward into more sophisticated levels, and then that sets us up well, because we also established a kind of a baseline for the incoming residents. That actually the same person, Mitch Gitkin, who's our assistant dean for health system science, put together with the curriculum they have, the common curriculum that a program can use, which starts with like white belt, lean training, and so forth. And we just feel like it's just catching up with what they're expected to have anyway. But we now have actually a division of health system science in the Department of Medicine, and in addition to moving Mitch into that group for the educational part and others involved in education, we recruited a chief, Alan Walkie, who's really been very skilled and productive health system science researcher, and we've developed. It's really come together very well with our groups that do the large, do the big data analyses on outcomes and performance of different.
And health system science, is that taught over all medical schools, or this is unique to UMass Chan?
Well, I don't think it's as unique as we thought it was when we started. I think that it is touched upon in the curriculum of a number of schools, but I think calling it out the way we have is we're kind of on the front end. We're not the only one, but we're kind of on the earlier adopter kind of end of having that in medical.
This is very important. And, as we try to hire quality officers and things, and, we realize that even a physician, even after residency and fellowship and being an attending, there is a gap there. So I'm very happy to hear that you're teaching this from the very beginning, and then you're enforcing and reinforcing throughout the clinical years. That's fantastic. One last question that I ask all my podcast guests is, what does quality mean to you?
Well, so quality, I think, primarily means that at the end of the day, we're giving a consistently positive experience and positive outcome from the healthcare encounters that people have. So I think it really has to include both measurable outcomes, like not making errors and having improved efficiency and recovery and so forth. But I think it's also got to include the experience that we have to balance the need for financial sustainability with what the experiences are that patients have. And I think studying what improves patient experience, what improves patient outcomes, and helps us deliver care more efficiently. I think all of those things kind of blend together, and the analytics of health system science, I think, really help us to see how things we think might help and we implement what effects they actually have.
Well, I love that you said that quality is the experience, because we just moved patient experience under our system quality umbrella, because it used to be thought of as a different thing, but we actually agree with your definition that the experience counts. And the quality, part of delivering quality of care, is having best experience. By the way, not only for the patient and their family, that's for sure, but also for people who deliver the care to the patients. And that includes physicians and APPs and nurses and everybody on our staff. So that's wonderful. Thank you so much, Dr. Flotte, for being here today. I really enjoyed our conversation.
I did as well. Thank you for having me.
And thank you for listening. Quality Time is part of Houston Methodist Leading Medicine series of physician-led podcasts. So that you never miss an episode, subscribe to Quality Time. New episodes will download to your podcast device. If you enjoyed our conversation today, please consider rating this episode and sharing it with your colleagues. I appreciate your support. Thank you. And until next time, I am always listening.